Can you talk about other risks and complications that you've seen and how to avoid them?
Yeah, there was actually a paper that just came out recently looking at the MAUDE, MAUDE. This is the self-reported complications to the FDA with these devices. And the most common on that was subcutaneous emphysema. That is a laceration or false passage through the membranous wall. The membranous wall is only a few cells thick. And again, surgeons can penetrate that, and in our labs or clinically, when it's happened, no one has ever felt it. It's so thin. So the only way to avoid that is to have a direct view down the lumen of the Eustachian tube. And this is why I always recommend that you've got to be able to see both walls. With your clinical exam, you want to see both walls of the valve, not just one. It would be like looking at the vocal cords. And, if you don't see the valve at all, it's equivalent to looking at the epiglottis and you don't even see the vocal cords, but you're going to operate on the vocal cords, you wouldn't do it. And in this case, if you use a 0-degree scope and you don't get an angled view and all you're seeing is the torus, you're seeing, maybe one wall of the valve. It's like seeing one vocal cord and you're going to operate on both. So you want to see both walls, evaluate both walls, and you want to see both walls when you're putting the balloon up there. You wind up, as you run the balloon up, you hug the membranous wall. You're running tangential to it, so you're not going to penetrate it. But what commonly happens is the surgeons are confident, I can see everything I need to with a 0-degree. They don't see the membranous wall, but they say, well, I've got the torus there. If you angle off of the torus, it actually takes you through the membranous wall. That's how it happens. And in fact, there was a carotid injury, which I'm sad to say. And this was in one of the rail-based devices where there's a bendable rail and the balloon slides up on that. So you put the rail up into the lumen and you slide the balloon up there to do your balloon dilation. And I didn't discuss it in the article, but we've duplicated this in the lab, years ago. We knew this could happen with anything rigid. That's why we don't put rigid things in the Eustachian tube. So if you angle off the torus, what probably happened in that case was the rail went right through the membranous wall. That takes you in a vector straight toward the carotid. So in the article, they talked about the bony portion of the Eustachian tube where the carotid is in proximity. That's probably not where this injury happened. It was a stroke a week after the balloon. So there was a intimal injury and a pseudoaneurysm. So they probably poked the carotid with this rail. And undoubtedly, that's a membranous wall injury. So the balloon has safety devices for all of this. It's got a soft, round, 2-millimeter diameter tip that if you don't push it in fast and you watch it go up the membranous wall. Now, the Eustachian tube curves initially medially, actually dives behind the adenoid a little bit, and then it curves off toward the ear. And a lot of surgeons don't realize that because they haven't looked up that far. So the balloon is flexible for just that reason. So it's going to navigate that turn, and it's got that ball tip so that it'll push the mucosa aside as you get up out of sight. So as a surgeon, you're going to set it along the membranous wall, tangential to it, so you won't penetrate it. And then as it disappears out of sight, it's going to just curve around. The cartilage becomes increasingly circumferential, and so it'll just guide along there. So the other safety features are so you're normally going to feel the isthmus when that ball tip contacts it. And there's a little mark at 31 millimeters. This yellow mark should never disappear into the lumen because the average Eustachian tube cartilaginous length is 25 millimeters. So it should normally be sticking out about a half a centimeter from the orifice. And in the smaller kids, maybe stick out even more than that, maybe up to a centimeter in the smallest 8-year-olds. So you want to see that yellow mark is not going to go into the orifice. You're going to feel that little ball tip touch the isthmus. And so that's how you do it. So you insert it under direct view. Typically, you need an angled endoscope, not necessarily. If you can see both walls, you're fine. If you can see both walls with a 0-degree, you're fine. But if you can't, get out the angled scope. So that's how you avoid this problem of air emphysema. There's actually been reported cases of pneumomediastinum. This happens from the patient getting a false passage, didn't get recognized, and the patient blew their nose within the first week. So we always recommend don't blow your nose in the first week. No modified Valsalvas in the first week. Fortunately, no complications came of those. They all were self-limited. Some of them got antibiotics, but not all of them did. And there haven't been any other significant adverse complications. There have been some reports of tinnitus and sensory neural hearing loss in devices outside of the U.S. I'm not aware of. I'm sorry. There was one case of tinnitus in the MAUD report. That's the only one I know of reported with a U.S. device. FDA. Well, actually, we've got several approved devices now in the States. But of the reports that I'm familiar with, that's the only case of tinnitus I've seen in a U.S. product.
Okay.